Good morning. My name is Ambrazo. I'm the founder and CEO of MPN Advocacy and Education International. We are celebrating our 10th year here, and I'm so very proud of all the work that's been done in the MPN community. And the fact that we have 300 people joining us today is just magnificent. We've found that these webinars are extremely important to our MPN patients and caregivers. Today, we are talking about PV and Polycythemia Vera, and with us is Dr. Gaby Hobbs, coming to us from Boston, and she's just a delight and has so much knowledge about MPNs and specifically PV, and she is going to chat with us for a second, and then we have a ton of questions. Please send your questions along to myself or Mallory, and we will make sure that we'll try to ask those in the next hour. Please welcome Gaby Hobbs, Dr. Gaby Hobbs.
Hi, Anne, and thank you so much for having me, and thank you everybody for joining. I always really enjoy participating in all the MPN advocacy events. I think they're wonderful, and I know that there's probably some of my patients here, and we'll probably talk about this in my clinic tomorrow. So I really look forward to your questions. There's no such thing as a silly question, so please obviously feel free to ask anything you want. I'm always happy to try to answer, and if I'm not clear, then ask it again. All right, so why don't we start out by just orienting ourselves to polycythemia vera, or PV, like Anne said. So as you guys may all know, there are a group of diseases called myeloproliferative neoplasms, or MPNs for short. And there are several different types. There's basically three main types that are the most common, and that's essential thrombocythemia, that's characterized by high platelets. There's myelofibrosis, where patients can have scarring in their bone marrow and can have issues with having low blood counts and having spleen that's enlarged or have symptoms. And then, of course, the reason why we are all here is polycythemia vera, or PV. When we think about PV, we usually think about high red blood cell numbers. And although that is definitely the defining feature of this disease, patients with polycythemia vera can actually have elevation of all three blood types, which includes the white blood cell count, or WBCs, the red blood cell numbers that can be measured in several different ways with the hemoglobin and the hematocrit. And they can also have elevated platelets, which can sometimes be confusing. It's like, do I have two diseases or do I just have one? You just have one. And when we do a bone marrow biopsy in patients with polycythemia vera, we actually see that. We see that all blood cell lines are elevated. I would say almost 100% of patients, not exactly, but a lot of patients will have a mutation in a gene called Jack2. That mutation doesn't exist everywhere in your body. It exists in the stem cells in a patient's body, specifically the blood-forming stem cells in the bone marrow. And that mutation is responsible for this disease and for the abnormal growth of blood cells. Patients that have PV, in addition to having high blood cells, can also have lots of symptoms like fevers, night sweats, or itching. And they can sometimes also have an enlarged spleen, which is an organ that lives on the left side of our abdomen, underneath our ribs, that can get big and sometimes cause symptoms or pain or difficulty eating and those kinds of things that we can talk about more. So how do we diagnose PV? Usually by having these abnormal blood counts, having the Jack2 mutation, and having a bone marrow that looks like polycythemia vera. And then we need to think about treatment. And so we divide people into low risk for having blood clots and high risk for having blood clots. And those that are low risk are usually patients that are younger than 60, that have not had a blood clot before. And those that are high risk either have had a blood clot before or are over the age of 60. Patients that are low risk are traditionally treated with aspirin unless there's a contraindication for that to prevent blood clots. And then therapeutic phlebotomy, which is basically when you go and get a unit of blood removed, almost like a blood donation, to lower blood cell numbers. Recently, there's also been the addition of ropeg interferon as an option for treatment for patients with low-risk polycythemia vera, and I'm sure I'll get lots of questions about that today. For high-risk patients, in addition to doing the aspirin and also the phlebotomy or the bloodletting, we also need to give a medication called cytoreduction, a medicine to lower blood cell numbers to help prevent blood clots further. And we do that with several different medications. I would say the most common medications are hydroxyurea and interferon. And for patients that don't do well with those medications initially, we also have ruxolitinib or Jakafi, which is a very helpful medication to treat symptoms. There are also other medications that are being studied. And I would say the one that's probably most advanced in its study is a medicine called rusfertide. And that's a medicine that's being studied to help patients with PV to no longer need therapeutic phlebotomy. And so that's kind of where we are in the PV world. I guess the one thing I'll say before we move on to questions is, patients with PV can live with risk of having blood clots. They can also have symptoms, which can sometimes also prompt us to start treatment. And then the other thing, which I think is usually a source of anxiety and uncertainty, is that PV is a disease that has the possibility to progress or change over time, and it can change to a related condition called myelofibrosis or MF. And that happens somewhere between 10 to 20% of the time over a period of 10 years. And then very rarely, it can turn into another disease called acute leukemia. Thankfully, that happens rarely.
Yes, that's so true. Thank you very much for that summary, basically. And we have a ton of questions for you.
Okay, great. Let's get started.
To let everyone know, Dr. Andrew Kuykendall will be joining us. He's running a little late, but he will be here. Okay.
He's seeing patients probably with PV.
Yeah, he's probably with patients with PV. So we get this a lot, but because now we have so many other treatments out there and more to come, what medications are showing the fewest number of side effects in PV?
So I would say that in general, we're kind of fortunate in PV that the medicines that we currently have actually don't have that many side effects. And because we have more than one, we can also play around with them to make sure that we find out a medicine that works for you or a dose that works for you. So hydroxyurea, although it's not a new medication or an exciting medication, I would say that in most patients really doesn't have many side effects. I mean, certainly it can have some side effects for some patients. And then we have the interferons, either the older interferons like Pegasus and the new interferon like Ropig interferon or Besremi. And Besremi has really been a game changer in the world of interferons because it is really very well tolerated and doesn't really have a lot of side effects. Jakafi is also a medicine that's approved for Polycythemia Vera, and that's also a medicine that's very well tolerated and without a lot of side effects, with the exception of weight gain, which some patients really do find to be problematic. But in general, Jakafi actually makes people feel better, not worse. And then for the drugs that are being evaluated, rusfertide, the new medicine that I mentioned briefly, also seems to be pretty well tolerated actually, and is associated with at least anecdotally from what I've heard, patients feel better on this medication too. So it's not so much that we have medicines that have lots of side effects, it's just that we are looking for medicines that can kind of alter the course of the disease.
Yes. And how can one tell, we hear this often too, as you know, if one's PV is progressing?
Yeah, that's a great question. And it's something that I would encourage patients to try to think about mostly in the context of when they're seeing their doctors and not all of the time. Because one thing that's important to remember is that PV progression doesn't happen frequently. And so in all likelihood, in between visits, you're going to be okay. I know that's easier said than done, but it is an important mindset to practice because I do think one of the goals of, or at least for me, one of the goals of treating my patients is to help them have the best quality of life possible. And finding ways to put away that uncertainty and issues. And if obviously it's very difficult to do, then perhaps, sometimes we get help from therapists as well, because I think that managing that anxiety is very real. But to answer your question more directly, how do we know if somebody's progressing? So one very easy way to do that is by looking at the blood counts. If you're on a very stable dose of one medication and all of a sudden the blood counts are very, very low, well, that's a sign that maybe the bone marrow is, sort of getting tired, or there's changes in the bone marrow and the blood counts are changing. development of symptoms by itself, I think, is something that patients are very worried about, but having symptoms doesn't mean that your disease is progressing. And I think that that's an important thing to keep in mind. Similarly with the spleen, although of course it is in a way a form of progression, it doesn't necessarily mean that the disease is changing from PV to myelofibrosis, but blood counts and symptoms help us get a sense of where patients are with their disease.
And to piggyback that, what tests would you do if you thought a patient was progressing?
Yeah, great question. And so the first test that we do is a CBC, or complete blood count, where we get a sense of the levels of the white cells, the red cells, and the platelets. And in addition, it gives us a lot of information of what are the cells that are floating around there. Do we see what are called immature cells or baby cells that don't belong in the blood? So that can really give us a sense of, is something changing in the bone marrow? And then if we do think that something is changing in the bone marrow, then a bone marrow biopsy is something that we can also do to evaluate disease progression by seeing if scarring has developed in the bone marrow, or there are more of these immature cells. And many times we'll also do genetic testing. So as I mentioned at the beginning of the talk, Jack2 is a mutation that's present in almost all patients with polycythemia vera. But sometimes when patients are progressing, we'll see that patients pick up other mutations. And when we see those other mutations, that can also be an indicator of progression.
And speaking of Jack2, before I go to the next question, we hear from people on occasion that are Jack2 positive, but do not have any symptoms and really do not have the disease. They just have that mutation. And that, I find that fascinating. I think that's interesting.
Absolutely. So those patients and are patients that have a condition called CHIP, or clonal hematopoiesis of indeterminate potential. Talk about a mouthful. And it's a group of diseases that we're learning about more. And it's basically like precursor conditions or diseases that predispose to progression. Most patients that have a Jack2 mutation, but that don't meet the criteria for polycythemia vera because perhaps their blood counts aren't elevated enough or their bone marrow looks normal, will have this condition called Jack2 CHIP, are actually at risk of developing an MPN. So that's also something that can provoke anxiety, of course.
Yeah.
And we don't know exactly when those patients are going to progress, or if they're going to progress, or if they're at risk for blood clots. And so that's something that we are learning much more about. And sometimes if those patients get tested for that mutation, it means that something is going on that prompted that test. People don't usually go around getting genetic testing, although maybe that'll change in the near future.
So back in the day, 20 years ago, I remember being at a function, an educational program, and the question was asked about the allele burden and what role the allele burden plays in MPNs. And I remember back then, things have changed because more research has been done. But I remember back then hearing from this professional that, that has nothing to do with anything. And in fact, it does. So could you answer that question about the role that the allele burden plays?
And I wish I could have a much, much better answer than you heard 20 years ago, but I don't. So it is likely that the high Jack2 allele burden does correlate either with progression or lower Jack2 burden can be seen in ET and higher can be seen with PV. Or even risk of having blood clots, but it's not something that's consistent enough, and it's not something that's really included in our current decision making. And so we don't really know what to do with it, not just the level itself, but we also don't know how to follow it over time. And that's a question that I get all the time, especially for my patients that are on the interferons. That's like, when can I check my Jack2 mutational burden again? And I hope that over the next decade, we really are able to solidify not just what does it mean to have a higher allele burden, but also what does it mean if my allele burden is going down? And, can we say that we've cured anybody or that we've really altered the natural history of their disease? And so not that different than it was before, unfortunately.
What do you look for in the bone marrow biopsy, for signs of PV? Like, what does it look like? I remember when we did an event in Australia and they had slides of what the bone marrow biopsy looked like, and it was really fascinating. It may be on our website actually, but what are
that'd
you
be great.
looking for? What are you looking for as a physician and researcher?
Yeah, so I definitely rely on my pathologists that have tremendous amount of expertise in distinguishing the MPNs from each other. Oftentimes we're actually surprised. We think we have a patient that has one MPN and then we do the bone marrow biopsy and it really looks very different. For polycythemia vera, the key phrase that we use is panmyelosis, which means all bloodlines are elevated. So we will see what's called a hypercellular bone marrow, or a bone marrow that's filled with tons of different cells. So there's not just a lot of red cells and the cells that make the red cells, but there's also lots of platelets and the cells that make the platelets and lots of white blood cells. And occasionally in PV, it's allowed to have a little bit of scarring, and that doesn't necessarily mean anything. But one of the things that we really do not want to see is a ton of scarring, because then that would be really consistent more with myelofibrosis. And so it kind of helps us to get a baseline of what is in the bone marrow. And sometimes it really does help to distinguish between patients where you're not sure if they have essential thrombocythemia or polycythemia vera.
How do you know when it's a good time to switch therapies?
Yeah, so it sort of depends on why a patient is on therapy and why we're considering switching. So if a patient is on treatment because they are considered high risk, those patients that are over the age of 60 and or have had a blood clot, if they're on a medication and that medicine isn't working, so you keep on adjusting the dose of the hydroxyurea, for example, and either at a higher level we have side effects and at a lower level we're not controlling the blood counts, then that sometimes is a reason to switch. Another common reason is, maybe patients are having side effects. Maybe somebody on hydroxyurea developed lots of mouth sores or a rash, or a person on interferon had a lot of abnormalities in their liver function test, or developed autoimmune thyroid issues or depression or things like that. So side effects of medications are a reason to switch treatment, and just lack of efficacy. Just like no matter how much hydrea you get, you still don't get to your normal blood levels. And then those are reasons to switch. And then another reason to consider a different medication is if a patient is having a lot of symptoms. So if, similar kind of rationale, you're on one medication and no matter what dose of that medicine you're on, you still have lots of itching, then it's pretty much, it's a good time to switch to another medicine. The itching with PV can be really impactful on quality of life. And so finding a medicine that helps for that is important. So symptoms and lack of efficacy are reasons for switching.
We know a lot of symptoms or constitutional issues, and we hear about neuropathy and itching and those that you mentioned. Could gout be related to PV?
Yeah, it could be related to PV, and especially related to PV at the beginning of diagnosis. It's not the most common thing that we see with PV, but certainly if somebody has very, very high levels of red blood cells or even white blood cells when they are diagnosed with PV, and then we lower those levels very quickly, then patients can develop gout. Again, it's not something that we see super commonly, but it can definitely happen. And if you have a gout attack in the context of a new diagnosis of PV, it doesn't mean that you're going to have gout forever, but it is something that you'll probably have to be monitored for.
I love this question. Is there any good news for those of us who are over 75, Jack2 positive, living a very healthy lifestyle without obvious comorbidities, and treatment models always put us in the high risk category? Speak to that.
Great question. So first of all, you said a lot of great things there. So you may be 75, but you're living a healthy, active lifestyle. So you're already doing a lot of things that you can in order to prevent having complications of the disease. And I think one thing to remember is that when we say that patients are high risk, we mean that they're high risk for having a blood clot, not high risk for having a bad outcome otherwise. And so when we're talking about blood clots and things that we can do to prevent those blood clots, what that patient is doing sounds like all the right things, having a healthy, active lifestyle, without having a lot of other medical issues. And so that's great news, I think, for that patient.
Yeah.
And, you know, the medicines that we have, like I was saying before, we have lots of good options without a lot of side effects that can help to prevent those blood clots further. And before I go on, I'll stop to have you introduce Andrew, who's now joined us.
Dr. Andrew Kuykendall has joined us from Florida, Florida, Tampa.
Yeah.
And pretty soon we'll be able to say the weather is gorgeous here and you'll be sweltering hot in Florida. Usually when we speak in the winter, it's the opposite. We're dying here with 20 below zero. But anyway, welcome, Andrew. I'm glad to see you. And Gaby's been holding her own here with lots of questions.
I'm sure she's taking care of everything.
She is.
Yeah, you're good, Andrew.
She's good. See ya. No. Anyway, so thank you again for joining us, both of you. And we'll move on. We've got tons of questions as usual. And so the next question is, how can you manage low ferritin? Andrew, do you want to take that?
Yeah, I mean, so I think the first thing is to kind of understand why people have low ferritin. And it's kind of a double hit. So, you know, ferritin is obviously a marker of iron stores. And in patients that have polycythemia vera, most of the time they present with low ferritin just in general, because really they have this Jack2 mutation that's leading to kind of increased iron utilization to make these red blood cells on a chronic nature. And that's been going on sometimes for years before patients are diagnosed. And so typically patients present with a low ferritin to begin with. And then once they get started on treatment, you know, part of the treatment plan for low risk and high risk PV patients is to do therapeutic phlebotomies. And so then we do these phlebotomies, which further take more iron from them, you know, especially at the beginning when patients need a lot of phlebotomies sometimes to get to their hematocrit goals. And so we take a lot of iron from you and then make you more and more iron deficient. And so then those ferritins sit low. And, you know, ultimately, it's not that our goal is to get the ferritin to be low, but it's certainly consistent with our goal of you not needing more phlebotomies. It ends up being low. And that's when really the phlebotomies start to taper off because the iron deficiency makes it difficult to make as many red blood cells as possible. And so I think, you know, the question of how to deal with it, you know, in some patients, you don't need to deal with it. You know, it doesn't come with a lot of symptoms. Patients feel fine. They run with a very low ferritin, and they don't have a lot of symptoms that come from that. But I would say the majority of patients have some degree of symptoms of iron deficiency, whether it's restless leg syndrome, fatigue, brain fog, and some of these symptoms overlap with polycythemia vera in general. So I think that can be quite challenging. You know, in patients that are quite symptomatic, we've even done very kind of like cautious or low dose iron replacement, very, very closely monitored. The problem with giving a polycythemia vera patient a lot of iron all at once is they just rapidly use it to make red blood cells. And I've even had patients that, you know, have gotten IV iron and have had just severe, severe bone pain due to the rapid utilization of that iron to make red blood cells. And so you have to be cautious with iron replacement. Unfortunately, I feel like we haven't had too much success even doing that because they use that iron up to make red blood cells and then they're iron deficient and you just need more phlebotomies. The other thing is, you know, it could be a reason to start some sort of cytoreductive therapy because if you're able to limit the need for phlebotomies through some sort of medication intervention, then allows that ferritin to kind of climb over time. And, you know, I think certainly there's excitement around the development of rusfertide or PTG-300 as a potential way to do this because it so effectively controls or limits the need for phlebotomies. But there's also data with interferon, with ruxolitinib, probably with hydroxyurea as well, that says that if you're able to control people's need for phlebotomy, the iron levels will improve over time. And so, yeah, I mean, I think that you know, it really is you know, low ferritin is related to the disease, but it's also related to the treatments we give. And if we can kind of control phlebotomies without, or control the need for phlebotomies, we can sometimes improve that.
Okay, this will be for both of you. And it's a serious question and it comes up often these days. And that is, after being on Jakafi for 7 years, I'm now experiencing a lot of skin cancers. Should I consider changing therapies? And Gaby, do you want to start? And then we'll go back to Andrew.
Yeah, that's a tough question. I mean, many of the medicines that we use for polycythemia vera can be a skin cancer, including hydroxyurea and ruxolitinib. And, you know, it's hard to give individual advice about what to do for that patient and why that patient is on ruxolitinib and the benefits that that patient is deriving from ruxolitinib. You know, we have some patients that have had a lifelong history of having skin cancers. And so obviously their risk is going to be much higher when they're started on any of these medicines. And so we have to balance, if this patient had tremendous itching and lots of other symptoms, coming off of the ruxolitinib may be really difficult. And so we have to balance that when making a determination about whether or not it's worth continuing on this medication. If the patient is really not getting a lot of benefit from being on ruxolitinib in terms of symptoms, then certainly we can switch to another medication like an interferon, perhaps, that maybe is not associated with those side effects.
Andrew?
Yeah, I mean, we do see that increasingly. I think we're getting a larger number of patients who've been on ruxolitinib for a long period of time. We're obviously in Florida, where skin cancers are not uncommon to begin with. But we do see it, there's this real subset of patients that have a real tough time, right? Like really just like every time we see them, they've had 3 or 4 more skin cancers removed. And it's challenging because the alternative, like what's the alternative? Hydroxyurea, which also causes an increased risk of non-melanoma skin cancers, no therapy, which may not be as protective, for thrombotic risk. Interferon maybe, right? I think that at least we're getting better tolerated forms of interferon, so that becomes an option. I'm not sure about the role of nicotinamide as a preventative for squamous cell carcinomas. I mean, I think that was something that we got excited about a few years ago, but the recent data on nicotinamide as a preventative has not been as exciting. Yeah, so I think it really comes down to a patient by patient basis, and we have that discussion at the beginning. We always counsel on the risk of skin cancers with ruxolitinib, and then if they are happening with increasing frequency, we're talking about, okay, well, yes, this could be associated with an increased risk. Here are what our options are, and here are the pros and cons, and we kind of make a shared decision. But the problem is that the alternatives can sometimes be quite few, and so I think it really comes down to what makes sense to the patient. We've taken a few folks off of ruxolitinib. Myelofibrosis may be a little bit easier, right? Because you have alternative JAK inhibitors that are approved for myelofibrosis. We don't really know their risk of squamous cell, but in polycythemia vera, you don't have as many options necessarily. So it can become challenging.
Does CLL impact PV treatment choices or MPN trajectory?
Did you say CLL?
Does CLL, yes. Andrew, do you want to start?
Yeah. I mean, I would say, generally no. I think that they're kind of two pretty unrelated diseases. I mean, CLL is the most common leukemia in the world, so it's not uncommon to see that in conjunction with an MPN, just because CLL is quite common. I think I have 5 to 10 patients that have some sort of concomitant, low-grade lymphoma or lymphocytic leukemia. Occasionally, it can become a little bit challenging diagnostically, right? Because they can have some overlapping features, right? You can see anemia in both. You can see an increased LDH. Like CLL is known for causing hemolytic anemias that come with increased LDHs and anemia, but in MPNs, we also see increased LDHs and anemia. And so, I think that at academic centers, we're all very specialized in what we see. So most of our patients see like a CLL person and they see me. And we alternate care, and so but I don't think it necessarily impacts, in most cases, the treatments you give or the natural history of the disease.
Gaby, do you want to add anything to that?
Yeah, no, I think that what Andrew said is spot on, and occasionally you may need to maybe lower the dose of your Hydrea, for example, if somebody's going to start a new medicine for the CLL, or if that medicine is impacting the blood counts, and so sometimes you do have to kind of just pay close attention to where they are in their treatment. But for the most part, those two things are, at least for now, thought of as separate entities that don't impact each other.
So there are a couple questions here about Besremi versus Pegasus. And of course, we all know that Besremi is approved by the FDA for MPNs. And so this person is asking, after 2 years on Pegasus, I'm now dealing with bone pain, insomnia, nausea, and fatigue. Are these symptoms from my PV, or could it be the side effects from the Pegasus? And would it be optional for me to try Besremi instead?
Yeah, that's a good question. And I think, similarly to some of the other questions that you've asked us, I mean, I think it's difficult to give very specific advice to a patient about, whether or not they need to change their treatment. I guess the one thing that stands out to me is that it's kind of unusual for somebody that's been on a medicine for 2 years to all of a sudden develop a lot of really bad side effects to that medication. So I think it's probably worth exploring. Some of the side effects you mentioned could potentially be due to either the medicine or to PV, but some of them, like nausea, it's a little bit odd, and it's a lot bit odd that it'll pop up out of nowhere. But just to be more general, I would say I often get the question of a patient that's on Pegasus for a few years, and of course now there's Besremi, and they're like, should I switch to Besremi because it's new? And I would say if it's not, if it ain't broke, don't fix it. If you're doing fine on Pegasus, we really have no reason to think that ropeg interferon would be associated with better long-term outcomes or more reduction in that Jack2 mutation, which I know a lot of people are very interested in. So I would really only switch for insurance issues, or if you really are having lots of side effects, like, no matter what they do for dosing or how often you get it, et cetera, the patient is still having issues with their liver function test, for example. So maybe you can switch from one interferon to the other. But generally speaking, if somebody's doing okay with one medicine, I wouldn't necessarily go ahead and switch to another interferon, I mean.
Yeah. Any additional thoughts on that, Andrew?
Yeah, I agree. I mean, I think interferon side effects are challenging just because they can be quite varied. Certainly, and they overlap with the disease. Interferon is kind of an inflammatory treatment, right? It's interferons are inflammatory cytokines, and so I've certainly seen insomnia with interferon. Again, it is a little bit odd, as Gabby said, to happen this late in the game, but so I've certainly seen insomnia. I certainly don't think it helps with bone pain. I don't know how much it causes it, but it certainly doesn't help as much as we'd like it to help with bone pain. But to Gabby's point, I mean, I think in the patients I have that are doing well on pegylated interferon, we haven't really switched them over to ropeg. I mean, ropeg's approval was largely based on the successes of pegylated interferon.
Yeah.
It was the reason it got approved is because pegylated interferon is recommended and used. So I don't know if ropeg is going to offer any benefits for someone who's able to access pegylated interferon consistently, afford it, and is doing well on it.
What about itching? And, I know it's a common symptom. And is there anything other than Jakafi that you've used in your practices that seem to help your patients with itching? Andrew, do you want to go first?
I mean, I would say Jakafi is certainly very good as an itch drug. I think it seems to help pretty much everyone I've had that has had significant itching. But again, we've already talked about some of the downsides with Jakafi. So it sometimes seems a bit kind of like bringing a gun to a knife fight type thing when someone all they have is itching and you're like, all right, well, we need to go on this on ruxolitinib. But again, it's tough to say all you have is itching, because itching all the time is one of the most miserable feelings anyone can have. And so, patients are quite excited to get rid of that, especially if it's been something we've been dealing with for a while. As far as other things to help with itching, nothing. Certainly, we try antihistamines and things like that. Sometimes that helps a little bit. I would say it's largely unhelpful if it's truly PV related itching. I've heard about kind of like off-label things, vitamin things to help with it that are very much anecdotal as far as the benefits that have been achieved, and I would say they're so wide-ranging, and what I've heard has worked, it's probably not even worth mentioning them because they're sometimes quite odd. But what I say is, hey, if it's working for you and it's helping you and it's safe, then that's fine. I'd continue doing it. So I don't know if in the Northeast they have some interesting regimens. What do you think?
So in the Northeast, one of the things that we really do deal with is really dry skin in the winter months.
Yeah.
And that can make itching so much worse. So for sure, having good skincare is like an important part of what we have to talk about here. But yeah, I agree. I mean, I think that you do a little bit of trial and error with the antihistamines. Occasionally, medications like gabapentin or SSRIs, antidepressants can have like a little bit of a role for a little bit of those like kind of pain or itching type symptoms. But it really is on a case-by-case basis. Really nothing is as great, I think, as ruxolitinib for making the itching go away. One thing that I think I did want to just spend a second talking about is that some medicines can cause itching as a side effect. and it's important to really be aware of that. The interferons actually can cause tremendous itching in some patients. And because we're always asking about itching and treating, with medications to make the itching go away, sometimes we don't necessarily recognize that itching is actually developing as we're going up on our Robig dose or on our Pegasus dose. So I think that's an important one to kind of just be aware of. If you're somebody that's never had itching and all of a sudden you're on an interferon and you develop itching, it may not be the disease, it actually may be a side effect of the medication. And so that's an important thing to keep in mind because it's not that common.
And to that end, Gabby, I'll just jump in. To that end, if that is the case, I think sometimes we are also kind of prone to say, oh, you're having itching, we need to start ruxolitinib. If you're on it, like I've had patients be like, no, this is definitely the interferon. Like I didn't have this before I started it. So if that is the case, and you're not someone who absolutely needs a cytoreductive therapy, I would definitely give a chance for just to come off the interferon and see if the itching gets better before kind of committing yourself to ruxolitinib for itching that was more treatment related.
Yeah, great point.
Makes perfect sense. I've been seeing research popping up with good results about Metformin delaying progression of the disease, or is this something we should? Is this something we should be thinking about it or taking?
I don't think we're there yet. I've seen that there's early phase data trying to look at Metformin. We've looked at this with other things too, but I don't think the data that I've seen is sufficient enough to say that it really has a huge role at this point. But I think that it goes to show that I think the interest right now is figuring out how to target this disease early and prevent disease progression. I think that's where a lot of our research goes. With the caveat, it's very difficult to design clinical trials in that space because progression occurs over such a long period of time, and it's difficult endpoint to measure. And frankly, it's difficult to design a trial that could have toxicity for a group of patients that is you're not really willing to accept any toxicity there either.
Have you seen an increase in MPN diagnoses since COVID? And if I could just tell you from our perspective, every time we host a webinar and throughout the week, we get calls from new patients and emails from new patients. But Mallory is keeping a very close look at percentages of new patients that come to these events and our in-person events. It's astronomically high. Today we had 300 registrants, and I'm going to guess 75 of those were new patients. And so, consistently we're getting that. Are you seeing that in your practices?
Well, that's because Gabby's here. That's the
reason. I think that after COVID, during COVID, there was definitely a decline in everything, right? All of a sudden, nobody had any diagnosis of anything. And I don't know if Andrew, you saw this too, but a lot of patients came in thinking that maybe they had long COVID or, they had COVID or something else. And that really caused them to delay their treatment. And so I think that spike is probably as a result of that. But honestly, the other thing, in addition to having, good doctors like Andrew, these webinars and MPN Advocacy and other organizations like this really are great resources for patients to help them come out and to know what they have and to seek the specialized care. So I think it's a combination of, MPN patients in general tend to be very active online, and there's lots of great resources. But I do think that there was a spike after COVID. That's really not a real spike. I think it's just patients maybe finally are seeking the care that they had been delaying. I don't know, Andrew, if you have another perspective on that.
Yeah, when you look at our numbers year over year, we're not seeing more MPN diagnoses more than we saw kind of just before COVID. So I'm not sure if that's the case or not. I think you can make a biologic rationale for that. Certainly we know, that these Jack2 mutations occur early in life, right? So they're not something that the Jack2 mutations were happening because of COVID or not, but we also know that inflammation kind of does play a role in maybe disease, pathogenesis or progression or evolution. And so, when you have a viral illness that's affecting, virtually all of the population, you could certainly make the case that maybe this is the right set of events that could allow MPNs to come out. Or the other thing you could say is we get a lack of diagnosis of MPNs because people have no reason to get blood work done. Right. But then if you're having an increased number of patients that are going to see a doctor or seeking medical care, because of this, and then getting blood work done, you're going to find more cases as well. And so, I always think that's one of the biases for seeing patients, why young women get diagnosed more than young men to some degree, is because young women actually go to the doctor.
Go to the doctor.
And all the men that I see get diagnosed, they get diagnosed at age 50 when they've like first presented, because they're like, oh, I'm supposed to get a colonoscopy around now. But no, I mean, I think that'd be my two other reasons. I think you can make a biologic rationale for it, and anytime you have an increased utilization of healthcare and lab work done, you're going to catch more MPs.
Or, yeah, I think that's absolutely.
And then genetic testing has become so much easier that, oftentimes the primary care doctors can order that Jack2 test, so less are being missed maybe.
Right. And I get blood work every year, and most people I know are now getting blood work every year. And so, more people are being diagnosed sooner. What causes the random fevers that come with PV? I get them for no apparent reason, even though I'm on Jakafi.
Yeah, so the symptoms and their patterns in MPN are something that are going to be mysterious to us for a while, I would say. I have patients that definitely have cyclical symptoms that are hard to explain. And so I think that's part of it. I mean, there's many things that can cause those symptoms. And, changes in the weather can definitely impact. Changes in, menopausal status can also impact. There's many things that can cause these hot flashes and other things. Although certainly I have some of my male patients that when I asked about fevers and night sweats, they tend to have, they can also have some symptoms that occur at random and during the day and not at night. And so I think it's just a matter of being aware that you have that symptom, having a strategy for managing it, and also not necessarily, if this is kind of like something that happens to you, not necessarily thinking this is something bad that's occurring. This is just maybe, a reminder of the disease. But obviously if it's happening very regularly and affecting quality of life negatively, if the patient said that they were on Jakafi, perhaps they need a different dose of Jakafi to make sure that those symptoms are better controlled, but obviously making sure that there's nothing else going on that's causing fevers.
Andrew?
Yeah, I agree. I can't explain sometimes the cyclical nature of these things. I mean, certainly these the fevers, the constitutional symptoms, they're being driven by the upregulated inflammatory pathway, the JAK-STAT pathway, leading to increased cytokine production, and that can lead to odd symptoms and fevers in some and not in others. There's also very rarely, I've had a few patients on hydroxyurea that's complicated by just very high fevers when they're on hydroxyurea. I think that's one of the odder reactions I've seen with that. But it's happened in probably 5 or 6, and they start the hydrea, they get fevers up to 104, they stop it goes away, and it recurs upon retrial. So probably those people shouldn't take hydroxyurea.
Good idea.
Okay, this person, I'm loving hearing from all these different ages, by the way, of patients. I was diagnosed 4 years ago with PV based on a blood test showing that I had the Jack2 mutation. My platelets are very high, but all my other numbers are normal. I take a baby aspirin and Plavix to neutralize the platelets. Do you think, I know you are not seeing this patient, but do you think they should look at other drugs? And this person is 75 and feeling great. Yay.
Yeah, so again, I think it's difficult to give individual advice.
Right.
I mean, there are a few things in that, in those sentences that you gave us that give me a little bit of pause. So the first is, and to remind everybody, recommendations per guidelines for the management of PV and essential thrombocythemia for those patients that need it is a baby aspirin and just a baby aspirin. If a patient needs to be on a medicine like Plavix, there has to be another reason for that person to be on Plavix. They certainly should not be on Plavix because of their MPN in addition to their aspirin. And so that's something that, I'm not going to tell that person to not be on Plavix, but it's something that at least I hope they know why they're on Plavix. And then the other thing that you mentioned is, all the blood counts are okay, but only the platelets are high. And so that's something that also needs to be thought about. When a patient is over the age of 60, if they have a Jack2 mutation, if they have essential thrombocythemia or ET, they probably should be on the medicine in addition to aspirin to lower that platelet count. It's also possible that this patient did have a diagnosis of Polycythemia Vera, had lots and lots of therapeutic phlebotomies, and then as a result of the iron deficiency that occurs with the phlebotomies, that the platelets have gone up. And so maybe it's a situation where, like Andrew was saying, maybe this person needs a little bit of iron to help lower those platelets with some close observation. but because of their age and a Jack2 mutation, they probably need to be on a medicine to lower their blood counts as well. So a little bit of additional information is probably helpful.
Yeah. Anything to
I
add?
agree. I mean, it sounds like they're, you know, potentially a higher risk for thrombosis given the Jack2 mutation and the age. So we typically would recommend cytoreductive, whether or not PV or ET, would recommend cytoreductive therapy, be it hydrea or interferon or something like that.
What are some natural ways to minimize blood clots? This person has heard, you know, I'm one to always go look for what's the best thing to eat. And, you know, I drink tons of water, but this person is saying garlic, fish oil, avocados, for example. Do you recommend a certain diet, or what do you recommend to your patients?
I was hoping we were going to get this question so that I could put a pitch in for diet and exercise.
Good.
Andrew's going to laugh. So, you know, many patients, I think the most important thing to remember with polycythemia vera, right? We all worry about disease progression and life expectancy and all of those things that are obviously very important, but we need to remember that the primary thing that will impact PV patients is having blood clots. And so anything that we can do to minimize blood clots will obviously be helpful. And so there's many other conditions in addition to PV that also increase the risk of blood clots, like high blood pressure, like cholesterol, like diabetes, like obesity. And so to get to your question about what we can do naturally, I'm not somebody that's going to recommend supplements because those haven't been studied. So I can't tell you, you know, take this mushroom extract or this whatever, and that's going to help you, because I don't know. But one thing that we definitely do know, and we have tons and tons of data to support that, is that having a healthy, active lifestyle, meaning any type of movement that you can do during the day, is going to help you have a healthy cardiovascular system. And that will definitely reduce the risk of having blood clots and also help you achieve a healthier weight. And then in terms of diet, again, I wish that I could say, if you have 3 oranges in the morning, you're all set. It's not that simple. It's more about having a healthy, balanced diet that is free of high saturated fats and processed ingredients, and more towards, you know, the words that we hear all the time, which are true, not just for many other diseases, but also for MPNs. And that's primarily plant-based with some lean proteins, trying to avoid alcohol. There's lots of new data now that I know a lot of people are very angry about how really there's no amount of alcohol that is helpful for cardiovascular health. So those are really the things that we can do with or without PV to stay healthy. And it really is a natural way that I think to impact, you know, the symptoms that patients have with PV, having better outcomes, and potentially even impact disease progression.
Yes, I agree with all of that. Andrew, do you have anything to add to that?
Absolutely not. I will say, you know, we don't all need to move as much as Gaby does. You know, I think when you know, the Boston Marathon's coming up, I know that's going to be a big day, but you know,
So
a few miles every day is fine. You know, we don't need.
That's exactly right.
Yeah.
But you know, it's funny because I just read Sanjay Gupta's book about aging and your heart and brain and so on. I love reading about the brain, and I loved the 4 things he said were, you know, movement was number 1, you know, just to get yourself going, but, and to get rid of, you know, cigarette smoking and so on. But I've read a lot about alcohol also, and man, it's just not good for us, period. You know, unfortunately, in some cases.
I know.
But, all right. So thank you for that. Can one side effect of Jakafi be swelling in the feet or pain in the feet and difficulty walking? I haven't heard this one, but
I haven't heard that as much.
Neuropathy I've heard, but
yeah, I mean, if anything, you know, I think Jakafi can help with swelling sometimes, because I think there is some degree of swelling that comes from hypoalbuminemia. Jakafi tends to improve albumin levels and can improve swelling from that standpoint. You know, things to think about as far as swelling. Obviously, think about kidney dysfunction. You think about pulmonary hypertension can ultimately back up and cause some edema as well. And so, you know, I think there's some other causes, but I haven't seen too much with Jakafi causing pain in the feet and swelling.
okay. Let's see. Is there anything to combat weight loss or weight gain with Jakafi? You just mentioned some, you just talked about that, so I think we can move on. Here's one about hair loss and restless leg syndrome due to low iron. Can you?
Yeah, I mean, I think we talked a little bit about that at the beginning,
Yeah.
as far as hair loss and restless legs. I think, you know, avoiding phlebotomies, maybe very cautious replacement of iron, could help.
Would you recommend that if a second bivalent COVID booster becomes available, people with MPN should consider that?
Probably, but
Yeah.
we're all waiting, I think, for the next vaccine to
I
come
know.
out.
In
Everybody
fact,
asks me, when should I get my next booster?
Exactly. I talk to my pharmacist all the time, and I'm, you know, it's been 6 months for me, and I'm a little worried
Yeah,
about
you're
it.
not alone, Ann, for sure.
Let's see, we have so many questions. Do doctors have any information about mutations such as DMNT3A that have made Pegasus less effective?
Yeah, I mean, so I think that is data that is still new, or still kind of, you know, certainly in the interferon trials, it looks like maybe the presence of kind of these epigenetic modifying mutations may impact the effectiveness. I don't think that that's necessarily something that has impacted my treatment plan so far. You know, I think that I'm more driven by like CALR versus Jack2 mutations and whether or not I'm giving pegylated interferon or interferon formulations. I think there's better data for potential for disease modification in Jack2 mutated patients, even though it does help control counts with CALR, but I'm less motivated to start those patients on interferon. So yeah, I mean, I think it's something that we still need to look into as we get more data on whether or not, you know, it is. But I mean, it is, you know, I would say the data is a little bit concerning, because it seemed like, at least in one study, I don't remember the study off the top of my head, but it seemed like if you gave pegylated interferon to patients with DNMT3A mutations, actually it caused, you know, kind of the reverse of what we'd see, as opposed to maybe worsening of the disease as opposed to disease modification. So fortunately, we don't see that too often in Polycythemia Vera, so it's not something that comes up a lot, but something to keep an eye on.
I know you don't see pediatric patients, but what about young adults who are 18 to 30 that have been diagnosed with PV? And, you know, what are the hopeful messages you send to the younger patients, Gabby?
Yeah, so there's a lot of specific issues that impact our younger patients. And one of the things that I really like to talk about is that, you know, the studies that we have now, I think people can be very scary sometimes for a young patient. When they look at life expectancy, they're like, is this really going to be, you know, how is this going to impact me? There's been so much progress made in the field of myeloproliferative neoplasms and PV in particular, that if you're a young person, the studies that talk about outcomes really don't apply to you, because things are going to change in the next decade. I'm positive of that. We have excellent researchers and people that are dedicated to finding new medications for this disease all the time. In addition to that, to just looking forward to the future, you know, we also really think about, you know, are these patients that should benefit from, you know, medications like ropig interferon that have shown over time slowed declines in that Jack2 mutation. I think as a field, we're really trying to reconcile those data and try to understand how to interpret that and to use that for especially our young patients. If we can really, even if it's a slow decline in the Jack2 mutation over time, those young patients may be the patients to do that for. And then the other thing, kind of going back to my prior answer about diet and exercise, I think that really plays a very important role for this population of patients that are young and have their whole life ahead of them. Anything that you can do, and this is true for any age of your life, but of course it's very applicable for patients that are younger. Anything that you can do to keep yourself healthy will pay off later. And so I think that that's also something that can really help to regain some control that is lost with the diagnosis. And so I really try to focus on that and, you know, really help patients to make the most of trying to really like have a good quality of life, and remember that, you know, this is a disease that's going to be hopefully in the background, and that should be the goal of treatment. And we can get patients through a lot of the milestones that occur during, you know, the 20s and 30s, such as, you know, having children and going through pregnancy successfully. And so there is for sure a lot of hope for our young patients.
Andrew, would you like to add anything to that?
Yeah, I mean, I think I agree. I think that we even though we think about these diseases as being, progressive, that doesn't mean they progress in everyone at the same rate. And I would say my younger patients are the ones where the disease just doesn't change for long periods of time in the vast majority. I think it's anxiety provoking to get diagnosed with this as a young age because you start thinking about, okay, what does that mean? Like, the median survival is X, and this is going to progress. But then as Gabby kind of alluded to, you think about, okay, well, you're worried about what's going to happen when you're 35 or 40 and you're 20 now. Like for reference, like 15, 20 years ago, we didn't know what a Jack2 mutation was, right? And then, we didn't have any drugs that were approved. And so to think that I can tell you now what your life is going to be like at 40 or in 10, 15 years, I have no idea what the field's going to look like then. It's going to be completely different. And, as long as your disease kind of hangs on and stays, like there's likely we're going to come up with much better ways to treat this. They're going to render all of these prognostic ideas we have just completely useless at that point. So, I think the focus is on living as healthy a lifestyle as you can. Getting to have as tolerable symptoms, good quality of life as possible, and moving forward, and hopefully putting something in the rearview mirror.
Okay, next question for your patients who are young women of childbearing years. What recommendations do you make to them in terms of, making the decision to have a child? And then if you have a patient who is pregnant, what specific things do you do with that person? Gabby?
Yeah, so I think the first thing to know is that, you can have a child if you have polycythemia vera. And that's true too for essential thrombocythemia. I think having a good relationship with an OBGYN is important to, be able to monitor your blood counts closely, et cetera. One of the things that we know from our experience looking at the patients at our centers, and this has been proven by others as well, is that taking aspirin is really important to improve outcomes for patients that are pregnant. And this, most PV patients are going to be on aspirin anyway, but this is not always the case for our ET patients. So we generally actually recommend that everybody go on aspirin. You may need a little bit of different treatment. It doesn't mean that because you're pregnant, you need to go on an interferon or anything else. Certainly, if you're a patient that's on hydroxyurea, that should be discontinued during pregnancy for sure. And then we recommend having 6 weeks of a blood thinner after delivery to prevent blood clots, because that's a period of time where there's a lot of hormonal shifts. And so that's one of the recommendations. So, with close monitoring, certainly patients can have pretty good outcomes.
Andrew, any other comments?
Yeah, I mean, I completely agree. I think it's one of those things where you have to say, obviously that there is an increased risk of complications. Acknowledge that, but that doesn't mean that it's something that has to be avoided or any contraindication. We have certainly a subset of patients that we follow that we see predominantly because they're interested in getting pregnant. We're there to work with them through that and kind of talk about what the options are and get to that ultimate endpoint. I also give them personal experience and say, the difference between 2 kids and 3 is drastic. You may not realize that, so maybe don't have that 3rd kid. Just consider it. Certainly,
Andrew's still working through that.
I just heard this. I just heard this from a friend of mine. In fact, he said, I was at their house with 2 little adorable kids and she's pregnant again. And he said, oh my God, I don't know what I'm going to do. But anyway, it was cute. That's so true. I have PV and low B12. My general practitioner recommends a B12 supplement to raise my B12. But when doing so, it also raised my hematocrit above 45. So I'm being cautious about that. Is there a strategy for not having low B12, but not raising my hematocrit? Good question.
I'd take B12. Just go ahead and take the B12. I think interestingly, it's somewhat interesting because most patients with myeloproliferative neoplasms actually have very high levels of B12. And it's something to do with an upregulation of like the B12 transporter on blood cells or something like that. There's some data back in the 60s or 70s. But it was almost used as like as a surrogate for diagnosing patients with MPNs in the past, is that they would typically have kind of above the level of detection B12 levels. So that's somewhat rare. But if it is low, I mean, I certainly would not hesitate to replace it and then you know, and deal with getting the hematocrit down in a different way.
Maybe try to figure out why you're B12 deficient as well. I mean, like, you know, we can live with low iron and have some symptoms, but it really is pretty dangerous to live with no B12. So I think it's important to figure that out as well.
Yeah, that's a good point. Interferon, if interferon causes inflammation and I'm working against the interferon if I take a supplement, will I be working against the interferon if I take a supplement to reduce inflammation?
No.
No. Okay. Okay. How high is too high for CBC counts in the MPN world? I'm on a 6-month wait list to see a hematologist, and I'm currently only taking low-dose aspirin.
I don't like hearing 6-month wait list to see.
I don't like that either.
I don't either.
Will you call me and we can, you know, see where you live and try to get you in sooner?
Yeah, absolutely. I wouldn't wait 6 months.
But how high would, you know, so a CBC, you know, blood, you know.
There's not a threshold. If a person has abnormal blood work, it needs to be looked at. And it's not something that you should have to wait 6 months to be seen.
Yeah. Exactly.
Yeah, I mean, certainly, you know, to that point, you know, our goal, if that patient's not aware, our goal is to get hematocrit less than 45% in patients that have polycythemia vera. That being said, if it's just high counts and no, we don't know if you have a Jack2 mutation, you know, there's other reasons for high red blood cell counts that shouldn't necessarily be treated with phlebotomy. So,
right.
You know, it's important to have that evaluation to understand the diagnosis and then, you know, get those you know, levels to target.
And, you know, also important to note that although, of course, here we only think about polycythemia vera, it's much more common to have high blood counts from something else than from PV. So definitely making sure that we have the right diagnosis first is most important.
That's really thanks for saying that. How can you tell if a blood clot is forming? I mean, if you're just going through your day-to-day life and are there any indications or things that a patient should be watching out for?
Common question. And I would say it's not something you have to be looking for because it doesn't happen most of the time. Okay. If there is a symptom, like from a blood clot, it's not something that's going to come and go away. It's something that's going to come and let you know. So there's many ways in which blood clots can present. I think one of the common ones is the swelling of the legs, especially one leg and not the other, with some redness and tenderness. But certainly, you know, we have blood all over our body. We have blood vessels all over our body. So we can have blood clots in many different ways. And so I think going through all of that is most likely to cause anxiety as opposed to reassurance. And so I think focusing on the treatments and the strategies that we've spoken about in the last, you know, 30, 45 minutes about prevention is important.
Yeah, agreed. I think that it's not something that you can really kind of like keep a close eye out for. You know, when your blood stops flowing effectively, it tends to show up with some sort of symptoms. But again, most common places to have it, as Gaby said, is lower extremities. That's where, you know, we don't have hearts in our feet, so we can't really pump blood back. So, you know, it kind of just sits there with gravity takes effect, and that's where it tends to stop. But again, patients with MPNs are notable for having, you know, odd clots in odd places as well. So if symptoms are there, just make sure you get them evaluated.
I don't know if you two can describe this, but, you know, we talked earlier about bone pain, and this patient is saying sometimes their entire body just aches. And what's the difference between bone pain versus muscular pain? You know, is there a way to describe it? Do either of you, I mean, since you don't experience it, I mean, I can talk about muscular pain. I
mean, so the way to think about bone pain, I would say, and again, it doesn't always occur classically, but the idea in polycythemia vera and myelofibrosis of bone pain, and really active hematologic diseases, is that you have this bone marrow space that is inside, like in the center of the bone, right? If you've ever eaten bone marrow before, you know, your bone marrow is made up of fat and blood cells. And with myeloproliferative neoplasms, you have way more blood cells than fat, and it's very active. And it actually can cause this kind of expansile pain where the inside of the bone is kind of expanding outward. And it tends to happen in the bones that have the most marrow space. So commonly in the hips or in the middle of the long bones, like the femurs, sometimes even the sternum, and it can mimic chest pain. But if you start to have pains kind of that are reproducible upon like massaging your muscles, or if it's happening in joints, or if it's happening positionally, right? Those would be things that I think less likely bone pain. But really this kind of expansile deep pain is what we most often hear described with PV and MF, and it's very different than other types of pain.
So in closing, I'm going to let you two just give me or give us, all of us, your thoughts for the future. We kind of talked about it a little bit, but you know, what can you offer to the PV patients and caregivers that are viewing this right now in terms of the future, you know, what they can look forward to, and any insights that you have for PV patients? Gaby, I'll let you go first.
So yeah, we've definitely touched upon a lot of these things, and I really liked what Andrew said about how far we've come in the last decade. And I think that really is what gives me a lot of hope, and what I talk to my patients about to give them hope that the next decade is going to bring a lot of things. We're seeing lots of trials now. And so I know that the landscape for treatment is going to be significantly better in the next decade. There's a lot of MPN doctors that are dedicating their careers to those to that research and to improving the care for those patients. And so I think definitely I think it's important to have hope about that. And then the other thing is do what you're doing right now. Be an advocate. And I think that one of the things that's so impressive about the MPN community is that people really know how to be good advocates for themselves and find good resources, which I can't emphasize enough too. There's also lots of not good resources out there. Try to avoid those. But coming, you know, getting informed, being an active participant in your care, going to your doctor's office and having those questions based on what you've learned, I think is really helpful to getting, you know, the best available care. Not everybody sees a doctor that only sees PV patients. And so coming with information and good questions can also help you be a more involved and engaged patient.
Andrew?
Yeah, I mean, I think I'll echo many of those, you know, sentiments. The what's encouraging to me is, you know, we truly like gain ground in these diseases when we understand the diseases at you know, the disease biology. And I think that's something that may fly under the radar with patients, but we're understanding more and more about the disease biology of these diseases every year. And I think that with that, like that will ultimately translate into better treatments that do more than just control blood counts and reduce risk of thrombosis, right? I think that ultimately what the future holds is kind of mutation specific, you know, targeted directed therapies that, you know, can truly offer disease modification. And, you know, I think we're starting to already see that trend occur with ongoing clinical trials that are using you know, vaccine-based approaches, immunotherapy-based approaches, you know, monoclonal antibodies targeting driver mutations, right? And so certainly that was the exciting thing from ASH, was this, you know, monoclonal antibody directed against CALR. You know, that's not necessarily Jack2, but you also had at ASH, maybe more under the radar, you had basic science presentations showing that there is rationale for a mutation-specific JAK inhibitor if it could be developed. And then you also have people that study Jack2 who show that there is feasibility of being able to do that, to just inhibit the Jack2 mutation, as opposed to just Jack2 overall. And ultimately, if you're able to do that, there's this biologic rationale that ultimately could you know, eradicate the disease potentially. So I think that you have these kind of things that are going on under the surface that give us hope, you know, that ultimately should translate into clinical trials and clinic over the next you know, 5 years at least, I would say. But really that understanding of the basic science, I think to really make ground, you need that. You also need trials and you need money. And I think that we're starting to have way more trials and with more, you know, industry sponsors getting involved in this, we're starting to have more money flow in as well. And so with that, I think you can absolutely, you know, get you know, drastic changes in the field, and hopefully that'll lead to better outcomes.
Well, thank you both so very much, and you're welcome to stay on. We're going to hear from our industry partners right now. with their updates. You're welcome to stay, or if you have to get back to your patients or wherever you're going, that's fine with us, but we so much appreciate your time. And Gaby, good luck. I'll be watching for you. And
Thank you.
you know, I think it's great that you're doing this, running in the Boston Marathon. And Andrew, thank you so much. And take care of those kids and have both of you.
I feel like I'm running a
Thanks so
marathon
much.
every day.
I marvel at all of you, seriously. Having only one child and a career, it was very interesting. So I can only imagine for you too. But anyway, thanks again. And again, stay if you'd like. We're going to move into hearing from Insight Corporation, or Insight, it's not a corporation, and Kristen Murray, who is the Senior Oncology Clinical Nurse Educator. Kristen?
Thanks, Anne. I am so very pleased to be here today to represent Insight. And I would like to thank Anne and team at MPN Advocacy and Education International for giving me a few moments to speak about our company and its commitment to patients. Insight Corporation is a Wilmington, Delaware-based biopharmaceutical company committed to making a difference in the lives of patients through scientific discovery. Rigorous science is at the core of everything we do to discover, develop, and deliver novel medicines that will meet the serious medical needs in oncology and other diseases. We are committed to providing better outcomes to patients through the medicines we develop, the education we provide, and our support of the community. One of our most important commitments is to help ensure that appropriate patients may have access to the medicines they need. For this reason, we developed a patient support program called Insight Cares to help appropriate patients and healthcare providers access their prescribed medication. For eligible patients, Insight Care offers prescription insurance verification and prior authorization support, free drug, and copay assistance for those who qualify under the program's terms and conditions, as well as ongoing education and support from a representative. Information for patient access can be found at www.insightcares.com. We highly suggest that all eligible patients enroll in Insight Cares, even if they don't think they will need assistance initially. Circumstances change, and if an eligible patient is enrolled, we will be able to help the individual more quickly if needed. We are currently enrolling eligible patients in clinical trials for MPNs. If you're interested, please contact your healthcare provider. Detailed information about Insight's clinical trials can be found at www.insightclinicaltrials.com. Partnerships like the one we have with MPN Advocacy and Education International have been key in helping our understanding of the unmet patient and caregiver needs, including raising disease awareness and providing educational information to the community. We created a program called MPN Heroes to publicly recognize individuals who have excelled in caring for a patient or patients with an MPN or have advanced the science in MPNs to increase awareness and support in the MPN community. The nomination window is now open, and we are accepting applications through September 14th of 2023. Please consider nominating your MPN hero for this year's award. Programs like this allow Insight to use our resources to help improve the lives of individuals most impacted by the diseases in which we work. So thank you for the time, and thanks, Anne, for having me.
Thank you, Kristen. That was very nice. Thank you. And moving right along, we'll speak with or hear from AbbVie and Virginia Tejero, who is the Associate Scientific Director. Hi there, how are you?
Hi, Anne. It's good to see you again. Thank you. And thanks to MPN Advocacy and Education International for allowing me to discuss AbbVie's clinical myelofibrosis program today. My name is Virginia Tejero, and I'm an Associate Scientific Director in U.S. Medical Affairs at AbbVie. AbbVie is a global pharmaceutical company and a leader in the transformation of care for patients with blood cancers. We are striving to advance standards of care and bring transformative treatment options to patients, including those with myelofibrosis. We are currently evaluating navitoclax in myelofibrosis. Please note, navitoclax is an investigational agent and not currently FDA approved. So safety and efficacy are still under evaluation. So navitoclax is a first-in-class oral small molecule that binds to two proteins called BCL-XL and BCL2, which are pro-survival proteins that prevent cells from dying. So cancer cells can hijack the machinery that makes these survival proteins to keep themselves alive. And navitoclax binds to BCL-XL, which can cause myelofibrosis cells to die. And JAK inhibitors shut off the pathway that increases production of BCL-XL, making myelofibrosis cells susceptible to BCL-XL inhibition. Now, given the results seen in the phase 2 REFINE study, AbbVie has proceeded with 2 phase 3 studies in fall 2020, both evaluating the combination of navitoclax and ruxolitinib in myelofibrosis in a larger patient set. The first study, TRANSFORM-1, includes patients with myelofibrosis who have not received prior treatment with a JAK inhibitor and is evaluating the safety and efficacy of navitoclax combination with ruxolitinib versus placebo and ruxolitinib. Now, the second phase 3 study, TRANSFORM-2, is currently seeking more patients to participate. And this study includes patients with myelofibrosis who have worsening disease as evidenced by an enlarged spleen and symptoms despite previous or current treatment with a JAK2 inhibitor. Now, TRANSFORM-2 is an open label study, which means that patients and investigators will know what agent they are receiving and will evaluate combination of navitoclax and ruxolitinib versus the best available therapy, which is at the discretion of the physician and could include ruxolitinib, fedratinib, among other options. Now, we currently have more than 30 sites across the US for each study, and TRANSFORM-2 is still seeking patients to participate. You can find more information regarding the ongoing studies at myelofibrosisresearch.com. The site includes further information about each study, a questionnaire to determine if you might be eligible to participate, and a map of current site locations. So thank you very much for your time.
Thank you very much. I appreciate it. We will move right along to Pharmacentia and Denise McNeil, who's the medical science liaison. Hello, Denise.
Hey, Anne, how are you?
Good.
Congratulations on 10 years, by the way, too. That's wonderful.
Thank
That's
you very
exciting.
much. Thank you.
And thank you for the opportunity.
20
Say again.
20 years in the space, but 10 here. Yeah.
That's wonderful. And thank you. I do want to thank you for the opportunity for Pharmacentia to share some updates in the work and the research that we've been doing. You know, it's exciting to hear Dr. Hobbs kind of describe that PV, you know, it's related to an elevation of all 3 counts, right? All 3 cell lines, hematocrit, white count, and platelets. And that's something we talk about a lot at Pharmacentia. When we look at ROPEG interferon's ability to decrease all cell lines, we always say all counts count. So that was really important to hear her say that today. And she said some wonderful things up front too, especially related to the Jack2 allele burden. And that was a perfect segue for me to want to share the research that we're doing in PV currently. ROPEG is indicated for PV from November of 2021, but kind of along the lines of what Dr. Hobbs was commenting on, as far as what role does the allele burden play? You know, when we look at PV, is a high allele burden correlating to a worse outcome? So our ECLIPSE PV study hopefully is going to look to answer a lot of those questions. Pharmacentia is really dedicated to truly understanding the disease biology. And if we can truly make an impact, you know, in PV, when we look at dosing ROPEG interferon, if we dose it a little bit more aggressively upfront, especially in the titration period, does that correlate with a better long-term outcome? Will we have a better, you know, deep, durable control of a complete hematologic response for patients with PV? Does it effectively control the allele burden long-term? And how can that truly impact the disease course overall? So highlighting our ECLIPSE PV study is perfect for this conversation today. I do also want to share some research that Pharmacentia is doing for ET as well. We have 2 studies for ET. Our SURPASS ET is our global ET study. Sites all over the world, and that one is looking at the use of ROPEG in comparison with anagrelide in patients that are resistant or intolerant to hydroxyurea. And then EXCEED ET is our single-arm ET study that has sites in US and Canada, and both of these studies are open and enrolling patients currently active now. And for EXCEED ET, it'll look at the safety and efficacy of ROPEG in ET. And thank you again for the opportunity. And I do want to thank all the patients and families who do ultimately decide to participate in our studies. It's truly an honor for us to be on this journey with you. So thank you.
Thank you, Denise. Very much appreciated. Thank you. And so now we'll move on to Imago Biosciences, a subsidiary of Merck & Company, and Fernando Carabaja. Hello there, how are you? You're the Senior Director of Medical Affairs.
Yeah, thank you so much. Good afternoon, everyone. Good morning, good evening. This is my pleasure. It's a pleasure to participate of this meeting, and thank you so much for the invitation. So I'm the Global Medical Director, Senior Global Medical Director for hematology, mainly with focus on leukemias and MPN. So at Merck, for more than 130 years, we have brought hope to humanity through the development of important medicine and vaccine that are our focus. So we aspire to be the premier research intensive biopharmaceutical company in the world. And today we are on the forefront of the research to deliver innovative health solutions to advance into the prevention and the treatment of disease of our patient and the people. So we foster a diverse and inclusive global workforce and operate responsibility at Merck. So we are all accountable for delivering high quality products and services. We aspire to improve the health, as I had mentioned before, and the wellness of our people, so and explore also the access to our medicines and vaccines. All our action must be measured against our responsibility to those who use and need our products. So our progress in oncology, in hematology, is due to our large part to important and through scientific questions that we set out and answer with our clinical trials. Our focus on cancer research and treatment, we are very proud to deliver breakthrough innovation in oncology and in hematology that are helping to extend the life of the patients and certain type of cancer. We are recognized as a company in solid tumors, but we have now the possibility to enter into the hematology with our molecules and improving our portfolio with the acquisition of different molecules. So we support the cancer community. We work with the entire oncology community, advocacy partners, healthcare providers, and government and industry colleagues to create a program that help our patient and caregiver on their journey, as well to provide grants to organizations to support patients with cancer. Our focus mainly is in aggressive disease, not only in lymphoma, so our focus is on B-cell malignancies, and now with the acquisition of bomedemstat is to enter in the MPN. Thank you for giving us the opportunity to share with you our vision in hematology.
Thank you very much for being with us. We really appreciate it. And we'll move on to GSK and Susie Seitman, who is the Patient Engagement Liaison.
Thank you so much, Anne, and good afternoon. Thank you for allowing me the opportunity to speak with you today. My name is Susie Seitman, and I'm a Patient Engagement Liaison and nurse with GSK Oncology. GSK is a global biopharma company with a purpose to unite science, technology, and talent to get ahead of disease together. GSK is focused on maximizing patient survival through transformational medicines. Our focus includes immuno-oncology, cell therapy, tumor cell targeting therapies, and synthetic lethality. Our goal is to achieve a sustainable flow of new treatments based on a diversified portfolio of investigational medicines utilizing modalities such as small molecules, antibodies, antibody drug conjugates, and cell therapy, either alone or in combination. In July of this year, GSK completed the acquisition of Sierra Oncology, a California-based biopharmaceutical company focused on targeted therapies for the treatment of rare forms of cancer. The acquisition of Sierra Oncology includes momelotinib, a late-stage potential new medicine with a unique dual mechanism of action that may address the critical unmet medical needs of myelofibrosis patients with anemia. In August, GSK announced that the FDA accepted the new drug application, or NDA, for momelotinib. If approved, momelotinib will contribute to GSK's growing specialty medicines business with a U.S. launch anticipated in June of 2023. The NDA is based on the results from key phase 3 trials, including the pivotal MOMENTUM trial. The primary analysis data from the MOMENTUM trial were recently presented at the 2022 American Society of Clinical Oncology Annual Meeting and the European Hematology Association 2022 Hybrid Congress. To close, I'd just like to add that we are so grateful to Anne Brazu and the entire myelofibrosis advocacy community for all the work you're doing to raise awareness and educate patients and their care partners about this disease. We appreciate the partnership that we have with you, MPN Advocacy and Education International, and I thank you for this opportunity to tell you and your listeners about what we are doing at GSK Oncology. Thank you.
Thank you, Susie. That was very nice. Nicely done.
Thank you.
All right, we will move on to CTI Biopharma, and a familiar face to me and some of us out there, David Dubinsky, who's the head of Global Patient Advocacy. Hi, David.
Hi, thank you. So for everybody that doesn't know CTI Biopharma, our company's based out of Seattle, Washington, and we are the makers of Vonjo or pacritinib, which is approved for select patients with low platelet counts who have myelofibrosis. You can find more information about Vonjo on our company website or just Vonjo website itself. Just wanted to thank you, Anne, and I wanted to thank everybody that participated in today's meeting for letting me listen and hear. Really just because participating in meetings like this and hearing the concerns that the community has directly enables me to bring that back to the company so that we can continue to focus on education and things that are important to you. So thank you, and kudos for everybody for trying to be educated and work with their doctor so that you can live the best life you can with an MPN. So thanks.
Thanks, David. That's a very good, very nice way to leave that. Thank you. And we'll move on to Cartos and Andrea Blank, who's the VP of Medical Affairs. Hello there.
Hi, Anne. It's so good to see you. It's good to see everybody on this call today. I'll be brief in my remarks simply because I know that there are some great industry partners still left to go who have perhaps more direct therapies related to PV. So I'll just briefly introduce myself. I'm Andrea. I'm part of the team at Cartos. We currently are working on an MDM2 inhibitor, but the majority of our work right now is in myelofibrosis. For those that are interested on learning more, you can go to our website. Once again, the name of the company is Cartos, K-A-R-T-O-S, and be able to find more information. But I certainly, Anne, would love to hand it back to you, to the other industry partners we have on the line, and certainly those that are doing great work in PV.
Well, thank you very much. It's always good to see you, and I'll see you soon. And we will now move on to Morphosis and Elsa Levita, who's the Director of Patient Advocacy. Hi, Elsa.
Hi, Anne. Thanks for the opportunity to be here today. It was a great conversation. So Morphosis began as a research and technology provider over 30 years ago in Germany, and today we've evolved to a fully integrated commercial stage biopharmaceutical company based in Munich, Germany, and Boston, Massachusetts. We'll all be cheering for the marathon on Monday, and we are focused on the development and delivery of an innovative. Our pipeline consists of investigational cancer medicines in mid and late stage development, which includes pelabresib, our investigational BET inhibitor, currently being explored as a first-line treatment option for people living with myelofibrosis in phase 2 and phase 3 clinical trials called Manifest and Manifest We announced last week that Manifest-2 has reached its full enrollment milestone and is no longer recruiting new patients. As we present new data from Manifest and Manifest-2, we will work closely with Anne and her team to ensure that regular and timely updates on our studies are shared. And we anticipate that we will have top-line data to share from Manifest-2 by the end of this year. As a reminder, pelabresib is an investigational drug and it is not approved by any regulatory authority, and there is no guarantee. We are committed to people living with MPNs who need new treatment options in the first-line setting and beyond. And we are just so honored to work with patient advocacy organizations serving the blood cancer community with MPN Advocacy, really leading the charge. We strive to aid the community by creating and supporting programs that provide education, services, and tools to people diagnosed with myelofibrosis and other types of blood cancers and their families. We engage with the community through forums such as this one here today to understand the patient perspective and journey so that we may incorporate these critical insights into our research. So thank you for your partnership and your time here today.
Thank you very much, Elsa. And we will move on to protagonists and Joe Loers, medical science liaison. Hi, Joe.
Hi, Ann. How you doing?
Good.
Thank you for such a wonderful program today with Dr. Hobbs and Dr. Kuykendall. I am Joe Loers. I'm one of the medical science liaisons from Protagonist Therapeutics. Protagonist is a biopharmaceutical company located in the South San Francisco Bay Area. We are a small growing biotech company with 120 employees. Our platform is based on a proprietary peptide technology. Our lead investigational drug candidate is rusfertide, as was mentioned by Dr. Hobbs and Dr. Kuykendall today, or PTG 300. It is a synthetic mimetic of the natural occurring hormone hepcidin. Hepcidin regulates iron metabolism and controls the absorption, storage, and distribution of iron in the body. We are very excited to announce that our phase 2 REVIVE study, which compared rusfertide to placebo in 70 patients, 70 polycythemia vera patients, was recently unblinded in March and yielded positive results. As a result, we have moved forward with a phase 3 trial for patients with polycythemia vera. The trial, called Verify, has already begun and is currently enrolling. We are targeting 100 sites globally and looking to enroll 250 polycythemia vera patients. The Verify study allows both high-risk and low-risk PV patients to enroll and is considered an add-on trial, as Dr. Hobbs had mentioned. Rusfertide is added to the normal standard of care. It is randomized, placebo-controlled trial evaluating the efficacy and safety of a once-weekly subcutaneous self-administered dose of rusfertide in polycythemia vera patients. We have a patient website that if you have PV and you answer 9 questions on the website, it will help determine if you qualify for the study. It'll also reveal to you the cancer centers that have the study open near you within 150 miles. The website is www.polycythemiavera-clinicaltrial.com. Once again, www.polycythemiavera-clinicaltrial.com. On behalf of Protagonist Therapeutics, I want to thank Ann and Mallory for hosting this wonderful educational MPN program.
Thanks, Joe. And thanks to Mallory, because she sets all of these up and we're very happy she's with us. And to the doctors that were here today and to all of you, we so appreciate your support. And to the patients and caregivers, if you have further questions, please send those to us and we will try to get the physicians to answer those for you. Thanks again. And we're going to be on our way to the Cleveland Clinic on April 27th. If you're in that area, please join us. And in May 25th in San Diego, join us there as well. And then we will have several other webinars over the next several months. So we'll be in touch. Thank you. Bye.